Our next discussion is going to be about rescuing the heart and taking a closer look at why cardiac intervention is so critical in Duchenne. PPMD has had an ongoing commitment to cardiac care. We do have a cardiac initiative underway, and we always, like to discuss how the heart is a muscle too, and we need to be treating that as well. Cardiac disease is something that can affect all people with Duchenne. It can also have an impact on those with Becker muscular dystrophy and carriers, as we discussed earlier today. And while advances in respiratory care have improved those respiratory outcomes, dilated cardiomyopathy and heart failure remain the leading cause of death in Duchenne. And so in this panel, we are going to discuss the latest in cardiac care, and we're going to provide you some updates on research that's being done to help rescue cardiac function. And so I'm going to be joined today by Kathy Kinnett, PPMD's clinical care advisor, to lead that panel discussion. We have a great group of clinicians to join us today. And so we are going to start with Dr. Chris Spurney from Children's National, and he's going to provide us an overview of cardiac care. Dr. Spurney?
Thanks, Eric. Welcome, everyone. It's my pleasure to be speaking with you from Washington, D.C. I don't have the most elaborate background, but if you can imagine the Capitol and monuments and cherry blossoms, then that's a better portrayal of D.C. than this wall here. You can go to the next slide. So my talk is going to be about the heart muscle disease, which we call cardiomyopathy, that's associated with Duchenne and Becker muscular dystrophy. And then I'm going to focus on how we go about diagnosing DMD cardiomyopathy, and then the current management and monitoring of DMD cardiomyopathy. You can go next slide. As Eric just mentioned, actually, as the treatment of skeletal and respiratory muscles has improved, and our colleagues have done such a great job, it actually has allowed the cardiac disease to manifest more, and cardiac disease is now the leading cause of death in Duchenne muscular dystrophy. So that makes it quite important that the proper diagnosis and treatment occur so that we can improve the duration and the quality of life in our patients. Next slide. And this is basically a picture of what we are trying to prevent. The heart on the left is a dilated cardiomyopathy. And then as you can see, compared to the normal heart, the muscle walls in those lower chambers there are thinner, they're bigger, they're dilated, and you can't see here, but they don't have normal function. And you can see the normal heart there, smaller, much thicker muscle. And so we are trying to prevent this progression from that normal heart to the dilated cardiomyopathy. Go next slide. So we'll focus first on the diagnosis of DMD cardiomyopathy. Next slide. As an overview, it's really not, there's still a lot to be learned about DMD cardiomyopathy. And there have been some papers that have found some associations, but there's no real known significant relationship between the type of genetic mutation in a patient and whether they will or will not develop cardiac disease. Also, there's really no known relationship between the severity of skeletal muscle disease and cardiac disease. Kids can have a very mild skeletal muscle phenotype or disease and then have very severe cardiac disease, and the reverse, obviously. An example of that is Becker muscular dystrophy, where they have a more mild phenotype, but they actually can develop very severe cardiac disease in earlier ages, in the teens and 20s. Next slide. So, when we think about heart problems in most patients, you begin to talk about the symptoms that they have, and people will complain of, shortness of breath and swelling and other these kind of common things that we hear in our grandparents that are related to a weak heart and heart failure. And unfortunately, we don't really, the disease in Duchenne does not manifest that way. There was a study quite some time ago in 1990, but they looked at the heart from using many different kind of tests. And it basically came to the conclusion that any kid with Duchenne's by age 18, they all had some evidence of heart and muscle disease. It might be something mild or it might be something more severe, but they basically all had something. And yet when they asked these patients, anything bother you? Do you have any symptoms? The majority of them did not have any. And so here you've got the presence of muscle disease without the presence of symptoms. And some of that goes along with, obviously, the skeletal muscles weakening and the kids transitioning into non-ambulatory phases. But they still do not display any of these kind of common symptoms that we think of related to the heart. And really what can happen with cardiac dysfunction is more kind of vague, non-specific symptoms. And I've listed a few of them here, but it can just be something simple like an increase in fatigue, or they're just not doing as much during the day as they used to. They might not like to eat as much. They might feel a little nauseated, some vague abdominal pains, and then their sleep gets disturbed. And they don't sleep as well. They have more nighttime wakings. Orthopnea is the inability to kind of lie flat and breathe comfortably. And so things that you could kind of explain away for different reasons, and maybe they're just not feeling right today. But sometimes those can be related to the heart. And then you do have more classic symptoms, lightheadedness, dizziness, palpitations, chest pain that can be a little more indicative of a heart problem. Okay, next slide. This is a little scheme here from a journal article that shows the progression of heart failure in DMD. And you can see the cartoon, the first one drawing, is a little more of a normal heart like we saw in that pathological specimen with smaller size, thicker muscle. And then it progresses to the end there in that thinner walled heart with bigger chambers. And so we use a couple different tests to kind of look at the heart during this progression to help with the diagnosis and understanding what stage we're at with DMD cardiomyopathy. We'll go through each of those tests now. So go next slide. ECG and Holter monitoring are kind of our first line of testing. And this is, of course, when kids get the electrodes on their chest and we do a tracing of the electricity of the heart. This is basically a screen for arrhythmias. And it's quite important if they are complaining of any symptoms that could be related to an arrhythmia, heart racing, skipping beats, lightheadedness, a fainting episode. However, the unfortunate thing is that kids can have a normal ECG even while they're developing heart disease and they have an abnormal heart. And so a normal ECG is not really predictive that the heart is normal. And so that kind of limits the effectiveness of an ECG as a screening tool. The Holter monitor is a longer ECG, right? It's like a 24-hour tracing, and we'll hear a little bit more about these in Dr. McNally's talk later. And the picture I put here is an arrhythmia that was picked up on one of these Holter monitors. And these can be a later complication in the disease when the heart muscle is a little weaker, and they can develop abnormal heart rhythms, which is shown by these bigger, larger beats with the V's on top of them, and that's a ventricular tachycardia. Okay, next slide. So echocardiography is kind of our main workhorse for evaluating the heart. And you can see here these two loops. We have a normal heart, and basically we're looking at heart size and heart function. And these are the kind of the most important things as we think about DMD cardiomyopathy as it progresses to a larger dilated heart with poor function. So that normal heart, you can see, is beating quite vigorously, and it's also kind of a smaller size. And then the picture on the right, the DMD heart, you can see is a little more dilated, and you can certainly appreciate that the squeeze of the heart is much less than that normal heart next to it. So that's certainly what concerns us, because as that squeeze decreases, the efficiency of the heart as a pumping mechanism diminishes, and that's when symptoms start to develop of heart failure. So this is our main kind of tool in assessing cardiac size and function is the echo that the kids get. Okay, let's go to the next slide. Now, one of our newer tools that we're really starting to use a lot in DMD monitoring is cardiac magnetic resonance imaging, or CMR. And here you can also look at cardiac size and function. And hopefully you can appreciate a bit that the picture is a little more defined, clearer. It's easier to kind of see the borders of the heart and the heart function. And so as kids get older, their echo images kind of get poorer and poorer. And this can be related to scoliosis or some hyperinflation of the lungs, just age, getting bigger body size. And so we tend now to rely a little more on cardiac MRI because we can get a clear picture and have a better measurement of cardiac size and cardiac function. Okay, let's go to the next slide. The other important thing that cardiac MRI allows us to assess is what's called late gadolinium enhancement, or LGE. And this is indicative of fibrosis developing within the heart. And this is a contrast agent that you give the patient. It goes in, it goes through the body, and then it kind of gets washed away out of the muscle. And it will actually, in areas where there's kind of heart muscle damage and fibrosis, it doesn't get washed away as easily. And so it will stay there. And then when we take a picture with the MRI, it shows up as bright white. And so in these couple pictures here, the black and white images, there's a white arrow, which shows this bright white area in that darker myocardium. And so that is kind of a marker of cardiac damage and cardiac fibrosis that we begin to follow in these kids. And there have been studies that have shown that as the amount of LGE increases, we start to see poor cardiac function and then poor patient outcomes. And so it's becoming a very useful marker for us to monitor the start and progression of cardiac disease, because they can have the presence of LGE and still have normal function. And so we know that there's damage there that we want to start treating. The other thing that cardiac MRI allows us is some newer kind of research techniques. And these are those kind of colored images down the bottom. And these allow us to do what's called myocardial characterization. Basically, it just lets us see the process of fibrosis beginning in the heart muscle. There's swelling, there's inflammation, and we can begin to measure that using cardiac MRI before the LGE. So that might give us a way to treat these kids earlier to prevent that development of LGE over time. Okay, next slide. So we'll talk a bit about the management of DMD cardiomyopathy. Next slide. This is kind of a schematic here of how we approach treatment of DMD cardiomyopathy. In that green box is indirect effects, and it shows scoliosis surgery and the non-invasive positive pressure ventilation. So these are two important things that are just telling us that proper treatment of the respiratory system is very important for the heart. And so, as I said, as we have optimized respiratory therapy, we are now beginning to see more cardiac disease. But it's very important to have healthy lungs, and that kind of helps prevent or can slow the progression of cardiac disease. Now, in the red box, under pre-symptomatic is what I was talking about a little, where we try and treat these kids with medications before we get too far down the line in the development of heart failure. And so that's where we're focusing a lot of our treatment and management of DMD cardiomyopathy at this time. You can go to the next slide. Now, the little kind of diagram on the right is a little busy, but if you look, I put the red words there, stimulate cardiac fibrosis, and there are two lines there that point to kind of two hormones in the body, angiotensin II and aldosterone. And these are two hormones that can cause a lot of cardiac damage. And so the treatment is focused at decreasing the amount production of those in the body. And so those little red boxes show where these three types of drugs try to limit the production of those two hormones. The drugs are ACE inhibitors, and the names there, which you've seen, angiotensin receptor blockers, known as losartan, and then the mineralocorticoid receptor antagonists. Okay, next slide. This lists just some studies that have been done over time that show the benefits of ACE inhibitors. And that last line there, losartan has basically been shown to be equal to ACE inhibition. So some providers may choose one over the other, what works best for your child. Next slide. And then these are a few of the studies that have been done with the mineralocorticoid receptor antagonists. Eplerenone is a newer version of spironolactone. And then again, down at the bottom, they've basically been shown that those two drugs are similarly effective with benefiting the heart early on. Okay, next slide. So lastly, this direct effect in the red box. Obviously, as you begin to develop more heart failure, weaker heart muscle, we have other medications that we can use. And then we also have what's listed there under the non-pharmacological options, some devices and pacemakers. And Dr. Villa will talk a little bit about these in his talk, as they are, basically a separate talk on their own. Okay, next slide. So our last topic will be monitoring of DMD cardiomyopathy. Next slide. And there have been kind of over time a few consensus statements that have come out by the AAP and the DMD Care Considerations Working Group, and then the American Heart Association published one in 2017. You can go to the next slide. All three of these provided kind of recommendations of how to follow the heart in patients with Duchenne muscular dystrophy. So the first thing they said is these patients should get a full cardiac evaluation and diagnosis. Usually that's to hopefully establish a normal baseline, but some of that can depend on the age of diagnosis. Now their next recommendation does say a cardiac evaluation every 2 years until age 10, if asymptomatic. Basically, I recommend after diagnosis that we see them yearly, and I think a lot of people agree with that. And then the official recommendations say at age 10, you start to see them yearly as it is. So there's only a few years in there. I prefer to see them yearly during that time, and I would certainly recommend that to others. Obviously, if the kids develop symptoms, we see them sooner, and we may follow them in different intervals based on their symptoms. Okay, next slide. With cardiac monitoring, I mentioned that echocardiography should be routinely used. And again, that's measuring cardiac size and function, but it can get limited as they get older. And so we do recommend the periodic use of cardiac MRI. And that also allows us to look at, as I mentioned, cardiac fibrosis. And that can certainly change our treatment parameters. So as the kids usually get to about age 8 or so, they don't need sedation for an MRI. That's certainly when we begin to talk about doing yearly or every other yearly cardiac MRIs in patients. And then Holter monitoring is recommended, as I mentioned, for symptomatic patients. Next slide. Okay, so just to give kind of brief takeaways from that quick overview. Again, kids should be getting yearly cardiac monitoring after diagnosis. The kind of consensus for cardiologists taking care of these kids is that we like to talk about starting medications around age 10. These have been shown to benefit kids in the short term, and so we're hoping that they're going to have a nice effect as we follow them long term. Again, cardiac MRI, CMR, can be very helpful to monitor cardiac fibrosis, and I certainly encourage it in my patients. We also are trying to learn more and more about the heart, and so we certainly encourage involvement in cardiac trials and cardiac registries so that we can follow children, learn more about early treatment and its benefits, and find other treatments that might provide kind of new options. Lastly, if you're involved with a PPMD kind of sponsored clinic, usually there is a pediatric cardiologist involved. I certainly recommend that. It's a evolving field, it's a developing field, and it helps to have someone who's aware of ongoing trials and new medications to benefit your children. With that, next slide, I'd just like to say thank you to PPMD and, of course, all of you who've taken your time to join us here and learn kind of a quick overview of DMD cardiomyopathy. Thanks very much.
Thank you, Dr. Spurney, for that great overview of cardiac care. Our next speaker is going to be Dr. Chet Villa, who is going to be speaking on the importance of collaboration and the ACTION-DMD network. Dr. Villa is from Cincinnati Children's Hospital. It's all yours, Dr. Villa.
Thank you very much. Thank you, Pat, Kathy, Ryan, and actually all of PPMD for the opportunity. I'm happy to speak to everyone today on behalf of the DMD group with the Action Learning Network, led by myself as well as Dr. Kripe from Nationwide Children's Hospital. Next slide, please. I have no personal disclosures, but I will be discussing the off-label use of VADs, as you heard from Dr. Spurney. The next slide. The network has been funded by a number of device companies as well as generous support from a number of foundations, which you see here. Next slide. So the network is actually a learning network that was established in 2017 as a way for pediatric hospitals and heart failure programs to collaborate and improve outcomes for children and young adults with cardiomyopathy and heart failure. As many of you are aware, the number of neuromuscular cardiologists is pretty small, and to improve outcomes and quality in a timely and patient-centered way, we have to include multiple centers and multiple stakeholders at the table. That begins first and foremost with everybody here. That's patients and families, but also includes researchers and industry who are also at the table during this meeting. And much of the work that you've heard over the last couple of days has been pioneered by PPMD over the year, and they've taken a similar approach with many stakeholders. Next slide. So the network began as a group of 7 centers in early 2017 and has since grown substantially. It now includes over 45 centers in North America, as well as some collaborating centers further abroad. The DMD community knows better than most that timely improvements in clinical outcome requires the passionate advocacy of individuals and providers, but collaboration is needed to really translate these improvements across centers so that families can understand the best treatment options, whether they live in Albuquerque, New Mexico, Duluth, Minnesota, or Washington, D.C., where you have Dr. Spurney. Next slide, please. The first project from the network focused on improving outcomes for children and young adults with the most severe disease, which was just alluded to. These are children and young adults whose hearts weaken to the point where they require a heart pump or a VAD or ventricular assist device to help them. Next slide. You may recognize these faces, and I have no doubt that even if you don't recognize them, the faces and stories of other patients with DMD, Becker's, or symptomatic carriers who have required a VAD, you've also heard. Here you see me screen right, wearing a Chewbacca head, talking to Ricky during a pre-COVID clinic visit. I didn't realize that masks were going to become such a big thing, otherwise I would have kept that one for my post-COVID clinic visits. Next slide. However, even at one of the largest pediatric VAD and neuromuscular centers in the country, we've implanted a pump in less than 1% of the people we have seen over the last 15 years. In fact, my goal as a cardiologist when I see most of my patients is to never have a discussion about VADs. That would mean that their heart is doing well and doing everything that it needs to get them around, keep them out of the hospital, and doing and feeling well. Next slide. You heard a brief overview from Dr. Spurney just recently, and this is a similar schematic, again, showing basically the progression of disease from early asymptomatic normal heart to one where you get fibrosis in the heart, which then leads to weakening of the heart. And eventually, some people develop heart failure, where their heart is not able to meet the demands that the rest of their body poses. And it's this group where the heart pumps can be most helpful. Next slide. However, as I said, 99% of the people that I take care of, and for most of my clinic patients, they do not require a heart pump. And to overall improve outcomes, we have to focus there. And that's where we're getting to in terms of the phase 2 from the learning network and where the DMD population has really started to come in. Next slide. So earlier this year, we polled members or clinicians of the Action Learning Network and asked what the most pressing needs are for their centers. This may seem weird because on my initial slides, we were talking about all of the potential stakeholders. However, we weren't able to go through all of our usual ways of talking to families, talking to researchers, talking to industry, because COVID upset all of that. So we had a group that were stuck on email and couldn't say no to Zoom or those things, so we started there. The top 3 things that we are getting from centers was how to get on the same page about medical management. You heard a really nice overview from Dr. Spurney, but because we're physicians, none of us agree on doses, when to start, how to do it, all of those sorts of things. And so we're trying to get together and come up with an easy and simplified way that we can, or the most of us can agree on, so that we can accelerate things, get people on the right medications, get them on faster no matter what center they're on. And the next part is understanding the outcomes across North America, not just at our own centers. That's important because if you live at a terrific center, that doesn't mean they're the best at everything. We need to be able to benchmark ourselves against other places, and so that I can learn from things that Chris is doing or that Dr. McNally is doing in terms of research, and then we can apply those in a faster, speedier way. And then finally, the third group there, which I've already talked to you about today, is understanding outcomes for children and young adults who require a ventricular assist device, and a set of recommendations so that we can understand who that works best for. Those pumps are not perfect for everyone. In fact, they have a lot of negatives. However, we want to continue to advocate for access for patients with DMD, Becker's, or symptomatic carriers who do require those. And in a field where sometimes neuromuscular patients are poo-pooed or pushed away, we want to make sure they have access to what they need if it really is what benefits them. Next slide. So to that first point, we are finalizing a draft of the medication initiation and dosing guidelines that will marry the various documents that you heard from Dr. Spurney, basically from the American Academy of Pediatrics, the Care Considerations, and the American Heart Association, as well as data that's been published since 2017 to keep people up to date, not only in what medications work, but how we might be able to optimize their dosing in a more timely way. That is something we know from the adult heart failure literature and from dilated cardiomyopathy overall, that starting medications matters, but those doses matter, and we have to find a way to efficiently and effectively get people on the right doses that make a difference. Next slide. You've heard much of this already in terms of the bad outcomes, but the brief overview is that we have put together what will be the largest group of outcomes for DMD and dystrophinopathy patients who have received the ventricular assist device. That initial data is coming to us right now, and by the end of the year, we hope to have that distributed to other centers as well as to patients and families. That's important because right now we're still in the process of figuring out who does best at this and how this impacts not just survival and long-term outcomes, but also quality of life. So that way we can give patients and families the right information so they can make the right choice for them with the support of families and with PPMD to move things along in the way that they would like. Next slide. We'll begin our prospective data collection, that third point, this fall. So this is my first ask to you, that to be able to move forward in understanding optimizing doses and optimizing total outcomes, we need prospective data. We need to know information right now, not what things were 5 years ago, not what people were doing 5 years ago, right now, and to be able to move forward in a timely and effective manner. Next slide. So here's my last ask for everyone here who's watching. We began our project, as I said, by talking to clinicians to ask them how they might best be able to deliver care because they were a captive audience. We now have a little gasp where many of us are catching our breath for COVID. So we're going back to clinic. We're trying to engage family and understand what they want. However, this is one of the largest gatherings in the world for patients with DMD, BMD, and for carriers. And we want to call out to ask what kind of things you guys need so that way you can stay in the conversation and that we can start to focus on things that you need, not just on what we are focused on and what we think is important. Next slide. So with that question, I'll move on to the first polling question. So what cardiac education and information would you guys find to be the most helpful? Please select all that apply. Information about cardiac medications. This includes types of medication, appropriate dosing, when to start, those sorts of things, as well as what to expect from cardiac test results and procedures across the lifespan. Much of what you heard from Dr. Spurney is terrific when you can come to these sorts of meetings. However, we want consistent and effective information for families to access at all times. And then also for options to manage severe heart failure. Next slide. And then the other polling question, which you will also go out, is where would you most likely to read or access this educational material about the heart? Print, online webinars, and videos. So those will come out with the when Ryan does the next set of polling. Next slide. So thank you to everyone, Pat, Kathy, and all of PPMD. You're integral to what we do on a day-to-day basis and for advocating for many of our families. Thanks to Linda and the rest of the ACTION-DMD group for helping to put together much of this data. We look forward to talking to you guys next year about some of that data that is currently in the pipeline. And also, finally, thanks to Angie Lortz and David Rosenthal. Those are the two that helped found the Action Learning Network, and it is on their shoulders that we're trying to build upon those initial phases and further expand our understanding for people with heart failure, including those with DMD. Thank you.
Thank you, Dr. Villa. We look forward to seeing the results of those polls when we do that in our next section. And our next speaker is going to be Dr. Beth McNally from Northwestern, and she's going to discuss loop recorders in cardiac research. It's all yours, Dr. McNally.
Great, thank you. So I am going to start out today, if you go to the next slide, with my overview is going to be talking about how the heart changes over time in DMD. I'm actually an adult cardiologist, so most of my Duchenne patients are above the age of 18, and so I get to see a different phase of how they're doing, and I will say I see a remarkable change in those who've received steroids, and so we'll talk about that a little bit. We'll talk a little bit about some of our effective treatment options, which we've heard a bit about, and then we'll focus on cardiac rhythm monitoring, steroids in the heart, and how some of the new and emerging treatment options that are in clinical trials may affect the heart. So with that, next slide. So just to remind everybody, the role of the dystrophin complex is that it stabilizes the surface of muscle cells and the surface of heart cells. And so we know that this complex is really important for both of those types of cells. And in the next slide, there are actually some differences between the muscle and the heart cells. We talked that the heart is a specialized muscle, but it in fact has some slightly different features to it in that the overall cells are each smaller. They're not as long as what you see in skeletal muscle, and they have a very different arrangement in that they're layered in circles. And the heart, once it's injured, has very little in the way of regeneration, potentially less inflammation, and it has very different innervation. And so all of those things make the heart have a different timing of disease than what we see in the skeletal muscle in Duchenne muscular dystrophy. Next slide. We know that the mutations that cause skeletal muscle disease are largely the same mutations that cause heart muscle disease. And those are mutations that affect the very beginning of the protein and those that affect the middle, which are shown in the red boxes. In the next slide, looking at patients with Becker muscular dystrophy, where part of the protein may actually be present, it actually was shown from this paper now more than 10 years ago that if you have mutations that affect the very beginning of the gene and protein, shown in the box with a number 1 over it, that there actually is an earlier age of onset of having heart disease, whereas most of the other mutations in box 2 or 3 have a later onset, with box 3 having actually the latest onset of heart disease. And again, that was taken from patients with Becker muscular dystrophy. So a little bit of correlation of where the mutation is and when you might see the onset of heart disease. Next slide. Heart failure affects many different people across the age span. And where we think about it as having these different stages: people at risk, people who have some evidence of structural disease but no real symptoms, and then people who start to have symptoms, including very severe symptoms. And this is the typical picture of heart disease. But in Duchenne muscular dystrophy, or quite frankly, any neuromuscular disease, many of these features may not be so apparent. And Dr. Spurney talked about that a bit, because just the normal things that we're used to thinking about heart failure may not happen in somebody who cannot exercise and display exercise intolerance. So we have to be much more on the lookout for what those findings might be in Duchenne muscular dystrophy. Next slide. So I like to think about the timeline. We know that the heart can be affected even in young Duchenne patients, because we may see an increase in heart rate. And then over time, we can see a change in heart size and a decrease in heart function. And as Dr. Spurney talked about, we like to use MRI and echo to be able to monitor the heart function. And then with time, we can see very great degree of progression of the heart size getting larger and the function going down. We know our medications make a big impact in slowing that progression and changing the face of the way the disease works. And that's ACE inhibitors and ARBs, beta blockers, and aldosterone antagonism. And we also know that steroid use completely shifts this timeline to really stretch it out a lot more. And that's a timeline in years that I'm showing you there. Next slide. And so when we translate that to the different cardiomyopathy stages we might think about, we might see some abnormal EKG in stage 1 when a child's quite young. And we know that that gets pushed back more when that child has been treated with steroids. When we go to the later stages, like stage 3 and stage 4, where we actually have some decrease in heart function that we can see through imaging, again, we know that steroids changes that timeline. And some of that effectiveness is probably very much mediated by the effectiveness of the steroids on the skeletal muscle and the respiratory muscles, which secondarily help the heart function. Next slide. And that was reiterated in the earlier talks, which is that it's very important. Our mainstay of seeing how the heart is doing is really managed by using a combination of echocardiography and cardiac MRI, which give us really important pieces of information about how the heart is doing. Next slide. And just to put a plug in, it's critically important to be using ventilation or ventilatory support, which most of the time these days is non-invasive nocturnal ventilation, because we know that compromised breathing itself can actually lead to changes which can affect the right ventricle and the left ventricle, and thereby secondarily further impair the heart function. So for us, as we manage our patients in their late teenage years and into their 20s, it's very much a combination of what we're doing with our pulmonary colleagues. It's absolutely critical. Next slide. This is a retrospective study, which means that they went back in time and looked at how patients did who were taking steroids and who took steroids for a long period of time. So to be fair, this is not what we call a prospective study where we would randomize patients to receive steroids or not. This is a retrospective look, and so it's always biased when we do a retrospective look. But what this retrospective study on the next slide showed was that taking steroids for a long period of time is actually quite beneficial for the heart. In the red box, if you can barely make it out, hopefully, is that those who took steroids and took steroids longer actually had better preservation of their left ventricular function and better mortality overall, better survival. And so this is, of course, again, because it's a retrospective study, you have to be very careful in how you interpret it, because this is also people who could manage to stay on steroids for a long period of time and didn't have overwhelmingly negative side effects. So it may have been already selecting for people who were going to do better. But it is important that we do see some evidence that the steroids also have benefit for the heart. Next slide. So just a few words. We talked about the decrease in heart function, and that leads to symptoms or findings of heart failure. The other part of the heart is the cardiac electrical system, which we refer to as the conduction system. So the heart has to have a coordinated electrical flow through it so that it can beat in the appropriate way, meaning the top chambers of the heart, the atria, beat before the bottom chambers of the heart. And that's so the beating of the atria can effectively fill the ventricles. And then when the ventricles beat, that sends the blood to the rest of the body. We can monitor that electrical activity using the EKG, where we see a small P wave, which is just the little divot, the little curve that you see first. That's the atrial activity. And then we see the Q, R, S, and T part of the EKG, which is bigger voltage that we see on the EKG. And that's because the ventricle is bigger than the atria, and that Q, R, S, and T comes from the ventricle. And so first you see the P wave, which is the atria, and then following that, we see the Q, R, S, and T. And that's basically the electricity traveling through the heart. We monitor that by looking at EKGs, which you can do by putting stickers on the chest and getting a quick look. And on the next slide, we actually can see that there is some ability to predict the risk for irregular heart rhythms by just looking at some of the data we can get off surface EKGs and monitoring. And so if we actually start to look at what the ejection fraction is, we will see that there is some correlation of heart function with a decline of function and an increase of those ventricular arrhythmias. We also can see that, again, a correlation of having both irregular heart rhythms that come from the top chamber of the heart, which is the SVTs, also have that same propensity. So the more the heart reduces in function, the more likely we are to actually see irregular heart rhythms. And we know this from studies of adults with heart failure as well, that as the heart goes down in function, we are more likely to see irregular heart rhythms happening. And that's why we up our game in terms of monitoring once we actually see decline of heart function. Next slide. This is that surface EKG that I was telling you. We get about 6 seconds of recording of the heart when we do a surface EKG, so that's not a very long period of time to just see what the heart's doing for 6 seconds. But we can see some changes in Duchenne muscular dystrophy that are helpful. We can see evidence of heart injury, and we can certainly see some evidence of irregular rhythms, but again, just in a 6-second recording. In the next slide, we can do different types of heart monitoring, which actually allow us to see what the heart is doing for much longer periods of time than the 6 seconds we can get off the EKG. So most customarily, for years, we would use something called a Holter monitor. People may be familiar with this. It was a little box you would wear around your waist and a lot of different leads or stickers that would stick on the chest. Typically, you'd wear a Holter monitor for 24 hours or 48 hours, so quite a bit longer than 6 seconds. We would get a lot of good information from that, but pretty much a pain to wear a Holter monitor because of all the wires and things coming out of it. We also do things called event monitors, which can be worn for up to 30 days. Again, kind of a pain to wear because it has a lot of stickies and not that comfortable. What we've transitioned to much more in the last few years is something called a patch monitor, and that's shown on the right-hand side. The patch monitors are much, much smaller. You can see they just are sticky that goes right across the chest. It's bigger than a Band-Aid, and it does stick out a little bit, but it can be worn for as much as 14 days. The great news is you can actually take a shower with this, so you don't have to avoid getting it wet. You're not supposed to submerge it, but you can, again, live pretty normally for 14 days while wearing this. So we've transitioned completely over to using these patch monitors to get information for as much as 14 days. And we find this a very effective way at looking at how the heart is doing over a 14-day period of time. So much, much easier to do than what we used to use. And in the next slide, are some other examples of how we can monitor the heart rate. Probably many people are familiar with the heart rate monitors that you can wear on your wrist or sometimes across your chest, and that can allow you to see what the average heart rate is. There are also some devices that actually let you see what the heart rhythm is. And so there's a company called AliveCor that has a device that can fit on the back of your phone, and you can just put your 2 fingers on it from each hand, and that will actually give you a very nice tracing that shows up on the phone, and you can make a little recording of it and send that off to your doctor. And then more recently, over the last 2 years, we've gotten a lot more experience with using the Apple Watch, which actually has a very, in the later versions of the Apple Watch, that has an AliveCor band that works with it that takes some very nice tracings as well. And so that can give you not only heart rate information, but it can give you some information about what the heart rhythm is. Currently, these devices are really well designed to pick up irregular heart rhythms that affect the top chambers of the heart, but future versions of this will actually be able to give us more information than just atrial arrhythmias. On the next slide is actually what one of these tracings looks like from one of my neuromuscular patients. Again, you can send these right to your doctor so your doctor can see what they look like. And you can see that the tracings are actually pretty good quality and give us a lot of information about atrial arrhythmias as they affect the heart. They haven't quite built the app yet that sends it directly into our electronic healthcare system. I hope they invent that soon because it would make it a little bit easier, but I'm confident that will come before long. So in the next slide, the newest versions of these that we all actually find quite useful are what are called implantable loop recorders. So these are very small devices. You can see there's a coin next to them, the coin that's about the size of a quarter. So they're a little bit bigger than that. And these go right under the skin. There are a bunch of different makers of this. They get implanted in typically an office procedure. They can monitor the heart rhythm for up to 2 years. You do regular downloads once a month or so that your doctors can see what's happening to your heart. But these devices don't provide therapy, they just provide monitoring. But we have found these, what are called implantable loop recorders, or sometimes go by the name of link recorders. They're very useful because when we have a patient who has very decreased function and we're concerned whether they're having irregular rhythms, we can actually use these devices to much more comfortably monitor the patient and see how they're doing. On the next slide is actually when we do see signs or symptoms of irregular heart rhythms that are more concerning, we then move on to using more serious devices that can deliver therapies. So a pacemaker is a device that goes under the skin and the wires go into the heart, and that stimulates the heart for when the heart is going too slow. It will provide a faster rhythm. And a defibrillator stimulates the heart for when the heart is going too fast and it has to be suddenly slowed by delivering a small shock to the heart. And most of these are go under the skin and have wires that go into the heart, but there are also versions that work in the subcutaneous place, so under the skin where it doesn't have to go inside the heart as much, and that's for a defibrillator. In the next slide is an example of a defibrillator in action in a Duchenne patient. So this is a patient where you see the heart beating along, it suddenly goes too fast, and that's called ventricular tachycardia. And on the next slide is actually the shock, the small shock, very low electricity delivered inside the heart, and it puts the heart back into the normal rhythm. So we don't know when these irregular heart rhythms can happen. That's actually what we spend a lot of time trying to figure out. What is the risk of that? Because these can be life-threatening rhythms, and this is what we don't want to have happen to the patients. And we know as the heart decreases function, it has a greater chance for this happening, but we don't want to put these devices in people if they don't need it. And so we spend a lot of time using cardiac MRI-based imaging and monitoring to try to figure out whether the patient is best served by having one of these devices. In the next slide, if the heart really starts to have a lot of decrease of function, we have pacemakers that actually can help the heart increase their function, and that's called cardiac resynchronization therapy. I've actually used this in several of my Duchenne patients, and it has improved their function. Next slide. And this is an example of one of my patients who had what's called that cardiac resynchronization therapy, and it actually made him feel quite a bit better once he got that. He was having quite symptomatic heart failure. In the next slide, we do have a new study, which is being supported by the Department of Defense, and the lead site is at Johns Hopkins by Dr. Barth and Wagner, and PPMD is supporting aspects of it through our center, where we will correlate the telemetric data that we get in Duchenne muscular dystrophy from loop recorders with what we see in MRI. So the goal is, can we learn more from MRIs to actually predict better who's at risk for having irregular heart rhythm so that we can more appropriately deploy our therapies? In the next slide. But we do have a couple of newer approaches. So just in the last couple of slides, we know exon skipping has been approved right now. Gene therapy is close to getting approval, and then gene editing might be on the horizon. And what can we expect for how these therapies might affect the heart? Next slide. So gene therapy, we know, will correct skeletal muscle partially. They don't get the full dystrophin gene back, and so we know that it's not going to have absolutely full function. And so we think that the same thing will be true for the heart as well. By not putting back the entire gene, we probably are missing some aspects of it that may be important for function, but certainly what's being put back will have a lot of benefit for the heart. And so we can expect that as long as the gene therapy is also expressed in the heart, that it should provide some benefit for the heart function. In the next slide. Exon skipping, based on what we know in the animal models where it had been tested, we think some of these compounds may not fully have the same access into the heart muscle as it does into the skeletal muscle, but there still could be quite a bit of benefit by just improving the skeletal muscle. And so that will remain to be seen as the boys who are currently receiving these therapies get older and get to the stage where we can see more what's happening with the heart. That will be very important to look what's happening there. In the next slide, gene editing has been now considered for restoring the reading frame for a number of different types of primary mutations for Duchenne muscular dystrophy. In the next slide are some examples where, again, in the mouse model, we know that can be reframed by gene editing targeting to put back exon 22 to 24. In another mouse model, it also can restore the reading frame. And if you go back into these studies, again, done in animal models at this point, in the next slide, we actually do see evidence that it looks like it can correct the heart quite effectively. In fact, in some cases, even more so than the skeletal muscle. In the next slide is an example from a large animal model of Duchenne muscular dystrophy, a dog model, where they received AAV for producing gene editing. You can actually look at what happens in the heart, and quite remarkable correction of the heart was seen with this approach. And so based on what we're seeing in the animal models, it does look like gene editing might be quite successful for the heart, but that's a ways off before that's going to get into humans. And so I think I have just one more slide left. So managing the heart in Duchenne requires attention to both the heart function as well as the heart rhythm. You heard in the previous talks, multiple medications and devices are available to maintain both heart function and rhythm. Predicting the risks for irregular heart rhythms in Duchenne does require more research and correlation with imaging studies. And the newer therapies that we're seeing may act different on the skeletal muscle compared to the heart, but that's going to be an important area of future research. And so with that, I'll thank you. And I think we're going to go ahead and go back to Eric and Ryan and do some questions.
Thank you, Dr. McNally. We're going to bring the whole panel back together for a very brief Q&A section. So we are going to have that discussion led by Kathy Kinnett. So we will begin that in just a second. And I think, Kathy, you are good to go.
I was. Thanks so much, Eric. And thanks to the presenters. I think all these conversations about care and research and standard and harmonization of care are fascinating and so needed. There's so much that we don't know. Beth, with all of these clinical trials that are ongoing and the potential impact on the heart, what are some of the developing or potential outcome measures that we can use to monitor the heart during clinical trials?
Yeah, I think the imaging that both Dr. Spurney and Dr. Villa talked about is going to be the mainstay of how that's done. Echo is obviously the easiest to do because it's ultrasound and easy to do. MRI is very precise and lets us have a look at the quality of the heart and how the tissue is actually doing, whether there's fibrosis or scar present. But I'm sure MRIs and echoes will be the mainstay of how that's done. It is possible in some situations there may be interest in doing even biopsies of the heart to see what happens, but that has more risk associated with it. So that would have to be a different question.
Great, thanks. Yeah, it's always a big topic of conversation. Chris, are there instances where you would recommend starting medication before age 10? And can you talk a little bit about the difference? There's some confusion about ACE inhibitors versus angiotensin receptor blockers. Do you start one, both, either? How do you decide?
Sure. For the first question, one simple answer is if there's symptoms, and that can sometimes move you towards using a medication. Secondly is if you can get a cardiac MRI on a younger child, age 8 or so, or even sometimes if they're very compliant, age 7, and that MRI showed some evidence of late gadolinium enhancement, which is a concern for cardiac muscle damage or fibrosis, that would certainly be a reason to start that therapy at that point and not kind of wait until age 10. And so that is one of the reasons that we're trying to get cardiac MRIs done earlier on these kids so that we don't miss some child that's having kind of an early expression of cardiac problems. If their MRI is normal around age 8, we can certainly wait until age 10. If the parents are advocating for an earlier therapy, I also listen to that and we'll start it sooner. The second part of your question, remind me.
Oh, ACE inhibitor versus angiotensin receptor blocker.
Yeah, I think certainly the ACE inhibitors are more kind of commonly used. The angiotensin receptor blockers came out initially with some mouse work and kind of a model of Marfan's and having benefit at that point. And then there was one study that showed that they were both kind of equally effective. So I guess it becomes a little provider's choice. I usually choose an ACE inhibitor. There are some mild side effects. ACE inhibitors can be associated with coughs. And so sometimes if you are seeing some side effects, you could try the ARB as a second line therapy.
Okay. And how often do you recommend that cardiac MRIs are done?
Usually yearly is what if it's a younger kid and it's normal, you can wait a year. You want to make sure that it's covered by insurance and all those things. But from a going back to wanting to learn more about this disease, certainly having yearly MRI data will help us a lot as we kind of build that foundation of knowledge about the progression of cardiac disease.
Thanks so much. Chet, we have some issues with behavior in a lot of kids, younger people that have Duchenne specifically. How would you manage a child that had autism who maybe couldn't be in an MRI machine? Would you give recommendations?
Yep. So I think what we have done is actually similar to what you heard from Dr. Spurney, which is in an ideal world, we would get it at age 8 because we know about 15% of kids will have LGE before the age of 10, and that would, as you heard from Dr. Spurney, be our indication for starting a variety of therapies. In those people who cannot sit for an MRI, I have a very quick discussion about kind of risks and benefits, but I will tell you my personal approach is I err on the side of caution and start a little bit earlier so you'll get therapy in terms of starting at least age 10 and potentially earlier if we have some other more sensitive markers, be it EKG changes. Sometimes we'll measure some markers in the blood, those sorts of things. But if you can't get an MRI, it doesn't mean you shouldn't get therapy.
Thanks. Beth, what's your expectation of microdystrophin in the heart?
It's a really good question. We know it's an incomplete protein, and there are thought to be some important parts of the molecule that are not present there when you go to put that back, and those might be important for the heart, but that's all based on animal models. It'll be really critical for any patient participating in those trials that we follow what they do and check their hearts out. So I think overall it will have benefit. Whether it's going to have full function is really what the question is.
Okay, thanks. Chris, what's the level of confidence in extrapolating cardiac results from animal models to humans? And is there an appropriate animal model?
That's a very big question. The smaller animal models, the MDX, which is the kind of naturally occurring dystrophin deficient mouse, and then some of the kind of developed analogs of that, have not had the greatest correlation, especially from a cardiac muscle point of view. They have a much more mild cardiac disease. The dog model has a much more, can develop a much more significant cardiac disease that is a little more similar to the human model. And so most of the focus, or most of the thought, is that if you could show benefit in the animal model, in the dog model, that would certainly translate more to the human condition. Many limitations with the dog model, mainly cost, but the thought is that is a more pure or more comparable animal model to humans.
Yeah, that's always a tough question, but I knew that you could handle it. Beth, as you might imagine, many people are told that they have tachycardia. So are there types of tachycardia that can damage the heart, and what should people be aware of regarding tachycardia?
When I'm faced with a patient who has tachycardia, the first question we want to spend a lot of time on is figuring out where it's coming from. Is it coming from the top chambers of the heart, which are the atria? And generally that's got different risk associated with it. Still things we have to manage, but much less risk associated with it. And then sometimes tachycardia is coming from the bottom chambers of the heart, ventricular tachycardia, and we consider that much more potentially life-threatening. So for us, the big question is always figuring out where it's coming from. And that's why we get so obsessive about coming up with all our different monitoring strategies, because we want to catch it when it's happening so we can figure out where it's coming from. And sometimes we have to take some additional steps to figure that out. But first question is to figure out what is the type of tachycardia.
So if somebody has atrial tachycardia, is that damaging to the heart at all?
It depends. If it's atrial fibrillation, that's not necessarily damaging, but it is known that if people have a very high heart rate for a long period of time, that in itself can be damaging to the heart. And so we don't like that to happen either. So it's a big part of monitoring, and it's quite fortunate now that our monitoring has gotten so much easier to do than what it was in the past. And it's all very manageable is the other important part of it.
It's just really important to follow up with a cardiologist regularly and as they advise you to do.
A cardiologist who's knowledgeable about Duchenne, I would put that there too.
Yes, specifically. For carriers, because we just had the carrier panel, and you mentioned mutations that are more likely to cause issues with cardiomyopathy. Are those... Would that information in Duchenne then translate to carriers as well?
I don't think we have enough information to know that. I mean, I would say, fortunately, most carriers, have a very mild disease that affects the heart. Not that, we still want to manage it and take care of it. I have noticed there's probably more atrial fibrillation in carriers than what is in the general population. Again, all of it very manageable. It's just being aware of what's happening.
Okay. And if you don't have access to an adult cardiologist who has a lot of knowledge about Duchenne, are there other cardiologists that you would recommend that especially carriers are seen?
In general, the heart failure specialists tend to be a little more knowledgeable about this, but I have to say I'm also quite pleased. A lot of my electrophysiology colleagues who take care of heart rhythms are also pretty knowledgeable about genetics. They've really had to be.
Okay, thanks. And Chet, can you talk or just mention the harmonization of care? How will that benefit the community, and why are you guys working so hard to harmonize care?
But I think this is one where we've learned a lot from our adult colleagues who specialize in dilated cardiomyopathy, where initiation of medication matters, but so does dose. And every major study that really has looked at that has showed that the higher you can get somebody in dose and still tolerate it has significant benefits. That includes when you have more significant levels of dysfunction, and there's some preliminary evidence that suggests even earlier. So what we are trying to do is give clinicians experience from larger centers, say, hey, this is what we've been able to do. We've been able to get up to higher doses. Sure, there are worries about things that can happen, but generally they've been very well tolerated, and we need to be a little bit braver and more proactive early on when we have opportunity to really affect the long-term prognosis.
Thanks. I think we're out of time. So I just really want to thank Dr. McNally and Dr. Spurney and Dr. Villas. It's been a fascinating conversation. It's always one that's of interest to the community. So thank you all so much. And with that, I'll turn it back to the studio.